Welcome back to PM Express. My name is Stephen Enti, and I have with me in the studio hall Sidiwa, who is National Coordinator of the Universal Access to Healthcare campaign, and then I have Jonathan Adabre, who is Policy Analyst from ISODEC. I also have Nana Kofi Opong-Damwa, who is Policy Analyst of the MPP. Welcome back to the discussions. I'll come back to you. We've been talking about the problems of the NHIS, and it does appear that one of the fundamental problems of the scheme is funding. And Jonathan mentioned that we should aim at a progressive tax instrument to resolve the problem. Walk us through the challenges of financing and how you think we can get better and make it work for us as a country. Thank you very much.
Currently, if you look at the sources of revenue to the National Health Insurance Scheme, minus the statutory funding, what is coming from government's budgetary allocation, you have VAT levy, you have the Senate contribution, that is those from the formal sector, we have the insurance premium.
And the NHIL.
Yeah, that is the VAT levy.
Okay, that's the VAT levy,
yes.
Okay.
And then we have investment from the National Health Insurance Authority, and then other sources. Now I'm going to explain this. For India 2010 annual report, the disaggregation of these sources show that the VAT contribution or the VAT levy constitutes 64% of the total resource. Now, followed by VAT is the Senate contribution, that is the contribution from the formal sector workers, which is 20%. Now, from the contribution we have gotten from the premiums that you and I have to pay is only 5%. Then the investment they make contributes 10%. And then others, that is like the accreditation and those basics, and contribute 1%. Clearly, this tells you that the premiums, revenue from the premiums is relatively negligible. And that's why we civil society are asking, if it is because of this 5% that about 50% of the population, that is the poor, do not have access to healthcare, then we say it's not fair because they also contribute to the 64% that we are getting from the VAT. Again, like Jonathan mentioned earlier, it is because of this 5% that we have how many offices throughout the country in all the districts. Again, when we look at their expenses, the operational expenses in terms of administration, running of the office, salaries, cars.
It could provide more healthcare.
Two times, the cost is about 2 times how much they are raising from the premium. So it doesn't make any economic sense. So that is why we are saying that the VAT has clearly shown that tax is a reliable, it's a predictable and sustainable source of financing this very good and laudable and bold health initiative. So what civil society is saying is that we need to keep the VAT, keep the contribution from the formal sector, and then see how we can probably tax the system in such a way that we'll get a lot of resources or raise a lot of resources from the system, probably from the informal sector. Because that
but not everyone will be happy with more taxes to support the National Health Insurance Scheme.
It's how we do it, because if you look at the VAT, we contribute to it, but we don't really realize it. If you go to a restaurant today and buy a plate of food like 10 cedis, you contribute to the 2.5, about 2.5 to the healthcare, but you don't realize it. It's how we do it. Today we have telecommunications. Already we have telecommunications tax. Assuming that for a particular network, say like Vodafone or MTN, we have like 15 million subscribers. And in a year, each subscriber have to pay like 2 cedis, which is spread throughout the year.
Oh, I'm sorry, I have to keep you on hold, and I get onto the phone line. I'm told Ameto Kwame is joining us now. Thank you very much, sir, for your time.
You're welcome.
The argument here from the civil society group is that the NHIA and the National Health Insurance Scheme is not doing too well. Is that your own assessment from where you are?
Well, they would have to give reasons for why they are making such an assessment.
Well,
you cannot just say that an institution is not doing well, and that's
right.
So if I listen to their positions, I will be able to.
Right. The argument is that in 2009, the NHIA reported that the coverage for healthcare access was 67% of the total population. Now, moving on, in 2010, your report put that figure at 34%. So, if you look at this,
that particular issue was a contestation between us and Oxfam and its associates in this country.
Right.
And I think that since 2009, we've moved on. We've looked at it. We've said to them that you are dealing with figures that we have, that on a daily basis we are registering people, we are renewing cards. So if you want, you cannot use mathematical derivations from the premium that people pay and do extrapolation and say that this is the number of people who are registered or who have registered with the National Health Insurance Scheme. That is what they did. And we said to them that if you need any information, come to us. Our doors are open. We have the primary source of information. So if you go and do mathematical extrapolations, you may not be getting the correct figures. That was what we said to them. So if they come, we will be able to discuss issues of numbers with them. We do know that there is a certain level of error, particularly in cumulative membership, which is add-on on a regular basis as to what we have registered. We agreed with them that there could be a certain margin of error thereabout. But we also have what we call active membership, which is the number of people who have renewed their cards, old members who have renewed their cards, and then new members who have registered. Most of the members who have registered. So, yes, we may have some challenges with the cleanliness of the statistical data, but that does not make the position that we have wrong.
So your active members currently stand at 34% of the population. Is this good by your projections and what you are hoping to achieve as a health insurance scheme?
What figure did they put out? Because I'm not in the studio, so I haven't listened to what they...
Right, the 2011 report from NHIA, National Health Insurance Authority, says 34% of the population are active NHIS card holders, which suggests that they are, these are active members. This is equivalent to about 8.1 million of the population. Is this good for your projections and where you are heading? You are taking this scheme to?
It is the number of people. You see, people, the problem we have, and one of the reasons why I personally think that the one-time premium will be of help, is that people are most reluctant, if they are not sick, to just renew the cards and put them down. That is something that we have found. They will go and renew the cards when they are sick, and that is a difficulty. Because people even get to the hospitals before they find out that the card has expired.
But
you see,
you talk about
when people are not sick, they haven't gone to renew the cards. You cannot say that people are not utilizing the services that are provided by.
Yeah, but Ms. Ametakwame, already contributions that are coming in from premiums form a very minute percentage of the overall funding for the National Health Insurance Scheme. So, I mean, I can't get it. Will the one-term premium solve the problems that the NHIS faces?
You are talking about renewal of cards or active membership, which means that how many people, as the year ended, have come to renew their cards, and how many new people have been registered onto the scheme. And I'm saying that a one-time premium means that you do not have to renew your membership, or you don't have to go and pay your premium every year in order to be an active member. Once you are registered for the rest of your life.
Right.
That is what I'm saying.
Right. Is the NHIS in trouble?
We are not.
Are you near collapse?
You need to go. You need to do. You need to go to the provider institutions and really find out whether the NHIS is providing the services for which it has been established or not. But I'm sure if you go to the over 5,000 provider institutions with whom we are working, you'll find out that over 80% of people who attend those institutions are National Health Insurance subscribers. That you will find out. So on that basis, on a daily basis, how would you say that the scheme is not doing well?
So your records show that the scheme is financially sustainable. Let's get that clear. I mean, your CEO said in Tunisia, July this year, that the NHIS is not financially sustainable. Is that the position?
No, there is a difference between projections that we have made into the future, depending on the information that is available to us today. As of today, we are able to pay for services that are rendered to us, but we are saying that if we project into the future, and if indeed it happens that way, then mathematically it shows that something has to be done about the sources of income. That is what we are saying.
And what are you going to do about those sources of income?
You see, the sources of income itself is a function of the economy. Even at the present rate of the levy being 2.5% of VAT, if the economy expands the way it's been doing, it means that revenue will increase. But apart from that, we have asked the government to also look at other sources of income. So we are hoping that in the new law, they would consider those other sources of income.
Can you give us a hint? Specifically, what are the sources you are considering?
In this country, our law permits that those who are involved in motor vehicle accident, for example, are catered for under the National Health Insurance law. So we are saying that then it should be possible for a certain percentage of motor vehicle insurance premiums to be passed on to the National Health Insurance.
So it's more like more taxes then, progressive taxes.
No. If you have your vehicle and if it gets involved in an accident, we pay for the medical expenses of the victims. Why is it that the premium that you pay, part of it cannot be given to us to be able to render that service on your behalf?
Right.
It's not an additional tax.
Right.
It is what is going to the insurance companies that we are asking that a certain percentage be given to the National Health Insurance.
Right, Mr. Metakwame, I'll hold you there and get a quick reaction from the studios, and then later we'll come back to you. So, Ho and Jonathan, you seem to have some disagreements with some of the things that Metakwame is putting forth.
Yeah, thank you very much.
Yeah.
Kwame said that we based our research at that time on mathematical extrapolations. We disagree with him because if at one breath he also admitted that there were flaws in their calculations, because our report did indicate at that time that they were adding cumulative figures and that there was a need for them to disaggregate those who were having valid cards from those who have one-time registered and perhaps it expired or probably died or traveled. So over time, I think they looked into it and they did, and I'm happy he admitted. So moving beyond that, I'm also happy he admitted that there are some challenge in a way, because he said people do not register except when they are sick. I think it's a genuine...
And that's a major issue.
Yes, it's a genuine concern.
Did civil society groups consider this as a challenge before, coming out with your research findings?
That is the issue, because if you go to the field, if you go to the district, you will realize that to some extent there's some level of apathy. For those who have the cards, they go to the health facilities and they are not satisfied with the services they receive. One, there's a drug list that are covered under the National Health Insurance Scheme. So you will find a situation whereby somebody will go to the hospital with a valid National Health Insurance card and still given a prescription to go and buy some of the drugs that are covered under the scheme. There are instances when people go And the attitude of some frontline providers makes it difficult for them to access healthcare. So this over time has resulted in some kind of apathy among the general population, dissatisfaction, because if you pay for it, you expect to get a service when you fall sick. So one thing people are rather doing is that it's okay, if I will go and I still have to be billed, I might as well keep my money so that when I'm sick, I go and pay for it, because when I pay for it now through the insurance and I go to the health facility, they will still find a way of charging me anyhow. There is a genuine concern, and I think that there seems to be a disconnect between the National Health Insurance Authority and Ghana Health Service, because it's sort of a contract between these two authorities, where Ghana Health Service provides the services to we the Ghanaians, and then the National Health Insurance Scheme pays for it. But it seems there's no monitoring to ensure that the services that the National Health Insurance Authority is paying for are actually rendered to the people who subscribe to the scheme. And I think that's one aspect they have to look at, because if Ghanaians are getting services that probably satisfy them, they will encourage, people will be motivated more to enroll into it. I can give you an example. I had a community interaction with some women group in Aguna East District. We asked how many of them, there were about 10 of them, it was a focus group design, how many of them have ever registered for the National Health Insurance Scheme? About 9 of them out of 10 raised their hand. Then we asked them how many of them had active cars. It was only 1. Then we asked them why. Then they said that if the services, when they renew and they go to hospital, they will still be charged. They will be given prescription to go to some pharmacies to still pay for the drug. So they prefer to just stop and
sit back and just wait till when the bad time comes, then they pay. The issues. Nana, tell me, you heard Ameto Kwame saying that by their projections, everything is really fine. You don't think so?
Again, I'm going to raise the issue of honesty on the basis that we think that when there's a problem, it's only right that you put them out there in the public domain and engage the expertise of all and sundry. On the lighter side, Ghana is a country of 24 million coaches whenever it comes to a football game. And so perhaps on this issue as well, we can become an issue of 24 million health experts and then share our minds and share our knowledge on it. If there is no problem, the only question I want to ask is that the NHIA report stated that for 2008, and this report was presented in 2009, the utilization figure was 9.9 million. For 2010, which was presented in 2011, the utilization figure was 8.1 million. For 2011, which is yet to be presented before Parliament, and I'll be glad if Mr. Ameto Kwame could give us reasons why they're yet to present their reports to Parliament. I would, however, dare say that it's because of some of these figures which betray the true picture. It is 8.2 million. You can see a very steady decline in the figures, in the utilization figures. I was slightly disappointed when Mr. Ameto Kwame said that you cannot just sit there and use utilization figures because people do not go to the hospital. Point is, if the individuals have not gone to the hospital, they have not utilized the scheme. That shouldn't be an argument. If I haven't gone to the hospital, I haven't utilized the scheme. But utilization figures coming from the National Health Insurance Authority, these are not figures that we have extrapolated. We have picked these things from their own report, and it shows that it's declining. How else can you draw any other conclusion?
Well, let's get back onto the phone line. Mr. Kwame, if you're there,
I thought I could just...
let's hear if Mr. Ameto Kwame. Mr. Ameto Kwame, can you hear us? Well, I think we lost Mr. Ameto Kwame, so we'll come back to you, Jonathan. You were saying something.
In that case, I think I stopped specifically from Mr. Ameto Kwame.
Yeah.
And so I'm going to go ahead and say this. We think...
We don't have a lot of time.
We think that the way forward is that we'll have to engage everybody, service providers,
civil society
organizations and groups, and look at the problems as they exist and pull together our knowledge base on it to deal with the issues. Again, the easiest thing we can do with a system that exists now is to clear all the necessary bottlenecks to ensure that the credits that service providers take is given to them back within the 3 months mandatory period.
So they
that
can,
way,
they can
the
keep
flaws
operating.
that exist now would at least be reduced whilst we look for a permanent solution to all the problems. We would, however, want to take the opportunity to say that we brought this project, we thought it up, we thought it through, and we are deeply committed to it. We know exactly what it was that we set out to do, and if Ghanaians vote for us once again, we'll come back and ensure
that's what it is. Jonathan, tell me what you're saying.
Yeah, from Nana's figures of utilization, it is clear it's a coverage problem. If you have declining utilization figures, it speaks to the fact that the coverage has also declined. And the NHIS cannot be blaming civil society for using some other mathematical calculations in arriving at the figure of 18%, when indeed they themselves have revised their notes and brought down the coverage from 67%
to
34. That is a 33 percentage point reduction. I mean, in actual fact, we should be increasing coverage, not reducing. And so the reduction in coverage has translated into a reduced utilization of the services. The thing that he mentioned, which is that we are counting active subscribers. Of course, we have to count active subscribers, because there's no point holding a card and counting it when you are not able to use it. So there's no point counting people who are holding cards that they cannot take to the health service and attain services. But to deal with the issue of how to make this thing sustainable, we have said here on a number of times that the current system is fraught with challenges, serious ones, which makes the scheme unsustainable. And Mr. Kwame alluded to that somehow when he said the projections of future needs of resources indicate that there are challenges. So that is something we have to deal with as a country. When you are dealing with financing health care, it is health care, access to health care is a fundamental human right. And we cannot be tossing the ball between NDC and MPP as whether this particular party is managing it well. We started it and they are not doing it. If we come back, the problem of health financing goes beyond these two political parties. And we have brought proposals. We've said that, listen, let's deal with taxation. We are not collecting enough taxes in this country. So if you want to finance your health care, collect the taxes. You must
collect more taxes and
we have
push
problems,
them into
we have problems in the mining sector, in our natural resource sector, where taxes are not collected. We are simply saying, let's collect the taxes from these sectors, and we will be able to finance our healthcare services. We are saying there's so much wastage in the health delivery system, the cost escalation based on people's natural incentive. Because if you are saying, okay, bring me a bill when you have provided a service, of course, people will bring you bills because they want payment. So it has led to a certain level of unsustainable cost element within the financing scheme. So let's eliminate that. Let's do away with the wastage and make savings. And per our calculation, we are saying about 36% of the total spending can actually be saved, because that is constitute wastage in the system.
Right, I'll take your final words.
If I could just,
I'm afraid,
if I could just add the other element. We're also arguing that apart from the taxation and savings, if we also can make the aid that we receive from our development partners, if we can ensure that there's aid effectiveness, the quality of the aid services that we receive, we will be accumulating enough resources to finance our health system. So these are things that all of us as Ghanaians, as people who want to have quality access to healthcare, that no Ghanaian is denied of healthcare because of his status, either geography or financial. We all have to agree that these are things we have to do as a nation. And of course, there are examples. We don't need to reinvent the wheel. Others have done it. We simply need to open our eyes and copy. And people have to accept that there are challenges. There are serious challenges with the current scheme of things.
Yes, so we need to, as a country, accept the challenge as a whole. Hosido, I'll take your final words and then we'll wrap up.
Thank you very much. Like Jonathan said, healthcare is a fundamental human right, and it is enshrined in our constitution. Government is obliged to provide it for everybody. Again, as we sit here today, if you fall sick now and you want a bed at Kolebu, it's a problem. If you don't know somebody, it's a problem. 37 is the same. Those in the rural areas are having challenges. And these challenges are not limited to the NDC regime or the NPP regime.
Exactly.
It cuts across all these two regimes. So we're using this opportunity to tell Ghanaians, when it comes to the issue of healthcare, let's look beyond NDC and NPP. When you fall sick and you go to hospital, the nurse that's going to look attend to you is not going to ask whether you are wearing NDC color or not. So let's make healthcare a priority in this election. Let's put away the partisan colors and make it a priority. Challenge the people who are coming to seek for your vote as to how they can ensure that all of us living in Ghana will have universal access to healthcare at the point of need, such that when you are sick and you go to hospital, the government would have already put in place policies to raise a lot of money to provide a lot of facilities for the doctors, for the nurses, provide health infrastructure, make sure that there are trained health personnel such as doctors and nurses, midwives, etc., so that when you're sick and you get to hospital, you will be attended to promptly.
Thank you very much. Hall Sidua is the National Coordinator, Universal Access to Healthcare Campaign. Jonathan Adabre is Policy Analyst, ISODEC, and we were also joined by Nana Kofi Opong Damoa, Policy Analyst of the NPP. My name is Stephen Enti, and Ameto Kwame also joined us from on the phone. Ameto Kwame is the Public Affairs Director of the National Health Insurance Policy. And thanks to you out there for watching and sending us your messages. Join us again tomorrow for another interesting edition of PM Express. Good night.